Hello everybody, thank you for tuning in to watch my video today, and in today's video we're going to be looking at the high yield acute abdomen for finals, and this is part of the obstetrics and gynecology edition. So let's get started. So just a little bit about the medicine guide. So the medicine guide aims to support medical students throughout their entire journey at medical school. So I've got videos focusing upon how to support medical students to be the most successful that they can. So how to be successful in the pre-clinical years at medical school, how to be successful during the clinical years, how to get the most out of GP placements, how to get the most out of hospital placements, and how to succeed in clinical OSCEs. Also, I've got a paediatrics edition, such as looking at the high yield pathologies leading to a vomiting child, high yield congenital heart disease for finals, high yield rashes for finals, high yield limping child for finals, high yield genetic conditions for finals, and high yield child with mass for finals. Now this video, in conjunction with many others, is part of the high yield obstetrics and gynecology edition. So other videos include high yield chronic abdominal pain, high yield gynecological cancers. So this video is focusing on the high yield acute abdomen. There's also high yield obstetric emergencies for finals. And finally high yield STIs for finals. So let's begin. So in today's video I'll be focusing upon ectopic pregnancies, miscarriage, pelvic inflammatory disease, Haematocolpos, and finally ovarian torsions. Now, any one of these diseases can crop up as part of the Obs and Gynae SBAs, or it might even crop up potentially as one of the surgical SBAs as a cause of acute abdomen. So therefore it's quite important that you're comfortable with each of these diseases, and I'll go through some of the key points that you need to remember in order to get the high marks in your final exams. So let's get started. So firstly we're going to look at an ectopic pregnancy. Now if you have a look at the central picture, which is enclosed within a blue square, this shows a normal pregnancy. So in a normal pregnancy, the embryo will implant itself along the endometrium of the uterus. Now, if you have a look at the picture in the pink square, this shows an example of an ectopic pregnancy. So this is when a fertilized egg will implant itself anywhere outside of the normal endometrial lining of the uterus. For instance, the fertilized egg may be found in the peritoneum, it may be found in the cervix, it can be found anywhere along the length of the fallopian tube, it can be found within the ovary itself, and it can be found in the abdomen. So now let's look at the risk factors. So if you've previously suffered from an ectopic pregnancy, unfortunately this increases your risk of developing another ectopic pregnancy in the future. Other risk factors include endometriosis, tubal ligation, and salpingitis. Salpingitis is inflammation along the fallopian tubes. So let's look now at the signs and symptoms. So women will present with a sudden unilateral abdominal pain in either the right iliac fossa or the left iliac fossa. These women will suffer from amenorrhea 6 to 8 weeks after their last menstrual period. So that means 6 to 8 weeks after their previous period, these women will have noticed that they haven't had a period. These women will also suffer from vaginal bleeding, abdominal tenderness, breast tenderness, and adnexal tenderness. So that breast tenderness is quite important because it's suggestive of pregnancy-like symptoms, and that, coupled with the amenorrhea, so the lack of periods for 6 to 8 weeks, is highly suggestive of either pregnancy or an ectopic pregnancy, but you've got to consider the other factors. Okay, now a very key and high yield complication of an ectopic pregnancy is that an ectopic pregnancy can rupture, and that's very dangerous for the young woman, and it's also something that's very high yield and it crops up in final exams. So a ruptured ectopic pregnancy will present with localized guarding, peritonitis, a rigid abdomen, and unfortunately this will lead the woman to suffer from collapse and eventually develop shock. So in terms of tests, it's important that we measure the urinary beta-HCG because that helps to confirm pregnancy. Now, a normal pregnancy would involve a situation where the beta-HCG will double in value over 48 hours. Now, in an ectopic pregnancy, the urinary beta-HCG will be extremely high. Now, if it's greater than 1500, then this is very, very suspicious. So the next step would be probably to do a transvaginal ultrasound scan because this is diagnostic. This will be the key diagnostic imaging that's used to help differentiate between a true pregnancy and an ectopic pregnancy. And you can also do an MRI. So now let's focus upon the management of an ectopic pregnancy. So there are three possible routes that we can use to manage an ectopic pregnancy. We have expectant management, medical management, and surgical management. So let's look at this in slightly more detail. So expectant management involves healthcare professionals monitoring the beta-HCG over 48 hours, and at this stage we're expecting the beta-HCG to be less than 200 and it should decline. Now, if the beta-HCG begins to rise, or if symptoms begin to present itself, or there's an exacerbation of the woman's symptoms, then we need to consider a management plan. Now, this management plan would either involve more medical management or more surgical management. So, medical management of an ectopic pregnancy involves using methotrexate, because methotrexate is highly teratogenic. Surgical management of an ectopic pregnancy involves a salpingectomy or salpingotomy. So these are two very similar sounding words, but it's quite important that you understand the difference between the two. So a salpingectomy is when there's removal of the entire fallopian tube, whereas a salpingotomy is a surgical incision where it removes the fertilized egg, which is leading to the obstruction within the fallopian tube. So salpingectomy is removing the entire fallopian tube. Salpingotomy is a surgical incision removing that particular portion of the fallopian tube which is being blocked by the fertilized egg. Now, in exams, they will often give you a scenario of an ectopic pregnancy and you'll be given a list of different management plans that could be used to manage this ectopic pregnancy. So it's really important that you understand which situations are appropriate for surgical management, which situations are appropriate for medical, and which situations are appropriate for expectant management. Now, I think using this table, it's a very nice way of understanding the difference between expectant management and medical management. However, sometimes, from my own personal experience, I do sometimes struggle with understanding the difference between medical management and surgical management of an ectopic pregnancy. So I've highlighted the three key features which helps to distinguish surgical management from medical management. So if the woman is in severe pain, if there is a visible fetal heartbeat, if the beta-HCG is greater than 1500 units, this would suggest that surgical management is needed to manage the ectopic pregnancy. Furthermore, If the ectopic pregnancy has ruptured, then surgical management is your definitive form of managing the patient. Giving methotrexate will not help at all, because remember, when the ectopic pregnancy has ruptured, it's leading to peritonitis. So at that point, we definitely need surgery. Okay? So now let's focus on miscarriage. So there are 5 different ways in which a miscarriage can present. There's an incomplete miscarriage, complete, missed, threatened, and inevitable. Now, the key feature that I use to help me understand what type of miscarriage might be presenting in an SBA is looking at whether or not the cervical os has been dilated. Now, if you have a look at this diagram, you can see that I've drawn a pink rectangle around the incomplete miscarriage and the inevitable miscarriage because they both have features of a dilated cervical os. So that's really important. So out of the possible 5 scenarios, if the SBA mentions that the cervical os is dilated or that the cervical os is open, then that means the miscarriage can only be an incomplete miscarriage or an inevitable miscarriage. So that's really important. So looking at whether or not the cervical os is open and dilated will help you to exclude some of the other possible differentials. So let's start off with an incomplete miscarriage, and then we'll compare that with an inevitable miscarriage. So the incomplete miscarriage, firstly, it has a dilated cervical os. The woman will present with vaginal bleeding. Some products of conception will remain, but some products of conception have already been expelled. So that's why it's considered an incomplete miscarriage. Now, if you compare it to an inevitable miscarriage, so similarly, the cervical os is dilated, the cervical os is open, the woman is suffering from vaginal bleeding. Now, the products of conception are either seen or felt at or above the cervical os, and therefore it's an inevitable miscarriage. Okay? Now let's look at the 3 remaining forms of a miscarriage. So a complete miscarriage will present with a closed cervical os, the woman will present with vaginal bleeding, and the products of conception have been completely expelled. Okay? Now, if we looked at a missed miscarriage, the cervical os is closed, there will be no vaginal bleeding, no fetal cardiac activity, or an empty sac will be found during the ultrasound scan. And finally, we have a threatened miscarriage. So again, there is a closed cervical os, vaginal bleeding will be experienced, and fetal cardiac activity is present. So I think the key concept to take away is that if the cervical os is open and dilated, then you have to consider either an inevitable miscarriage or an incomplete miscarriage. Those are your only 2 differentials for an open cervical os. If your cervical os is closed, then you're left with 3 possible differentials: a complete miscarriage, a missed miscarriage, or a threatened miscarriage. So what I really want to highlight is that in the SBA, when the particular line mentions if the cervical os is open and or closed, use that key feature to help exclude some of the possible causes of the miscarriage, and then look at other features such as whether vaginal bleeding is present, to what extent are the products of conception expelled, can the fetal cardiac activity be recognised, upon the ultrasound scan to help guide you in terms of making your differential. But the most important thing is to be aware in your mind of what the possible differentials are if you've got a closed cervicals and what the possible differentials are when you have an open cervicals. Okay? So in terms of management, so the first line management is to wait 7 to 14 days for the miscarriage to spontaneously complete. Healthcare professionals can offer these ladies a vaginal misoprostol, and if that was found to be unsuccessful, then a manual vacuum aspiration could be considered. So the next condition that I'm going to cover is pelvic inflammatory disease. So the risk factors for pelvic inflammatory disease is chlamydia trachomatis, and that's the most common cause of a pelvic inflammatory disease. Gonorrhea is the second most common cause. Bacterial vaginosis, abortion, insertion of an intrauterine device, or this is more commonly known as a copper coil, or any form of gynecological surgery. So sexually active women with multiple partners who don't use condoms are more at risk of developing pelvic inflammatory disease. So in terms of signs and symptoms, these women will suffer from suprapubic pain, fever, cervical motion tenderness. So during the examination process, when the doctor presses upon the cervix, the woman will experience pain, and that is what's described as a cervical motion tenderness. Other signs of pelvic inflammatory disease involves an abnormal, unpleasant vaginal and cervical discharge. So complications of a pelvic inflammatory disease, and this is something that's very high yield, is Fitzhugh-Curtis syndrome. So Fitzhugh-Curtis syndrome can mimic cholecystitis or pyelonephritis because right upper quadrant pain is referred to the right shoulder tip. So this is because violin string adhesions have developed between the liver capsule and peritoneum. So if you have a look at the picture on the far right hand side, you can see examples of these violin string adhesions. Now this is a very key classic complication to be aware of in terms of pelvic inflammatory disease. It comes up time and time again in medical school final exams. Whenever there's any sort of SBA where a woman is suffering from right upper quadrant pain, referring to the right shoulder tip, and she has a current infection with chlamydia, gonorrhea, or she's recently had a copper coil insertion, then you need to consider Fitzhugh-Curtis syndrome, because that's what the SBA is hinting to and suggesting. Now, most medical students do get confused between Fitzhugh-Curtis syndrome and other differentials like acute cholecystitis or pyelonephritis, but the key thing to remember is that patients presenting with acute cholecystitis or pyelonephritis will not be presenting with an underlying STI, whereas women who are suffering from Fitzhugh-Curtis syndrome will be, and that's one of the features that hopefully you can use to distinguish between the different conditions. So if a woman is presenting with right upper quadrant pain referred to the right shoulder tip, and she has a history or an underlying STI and currently has copper coil inserted, then that's suggestive of Fitzhugh-Curtis syndrome and pelvic inflammatory disease. Okay? So in terms of tests, so we need to do a vaginal examination. So these women will suffer from tenderness in the uterus or the adnexa. Cervical excitation, so I've mentioned that before. So during the pelvic examination, when the doctor presses on the cervix, then the woman will experience pain. The woman might also have a palpable mass in the lower abdomen with abnormal vaginal discharge. We need to do a pregnancy test and also the NAT test. So the nucleic acid amplification test, the NAT test, is used to exclude for chlamydia or gonorrhea. And the gold standard investigation for pelvic inflammatory disease is to do a laparoscopy of the fallopian tubes, followed with a peritoneal biopsy and culture. So in terms of management, we can offer 14 days of antibiotics, so oral ofloxacin and oral metronidazole, or an alternative cocktail of antibiotics involves intramuscular ceftriaxone and oral doxycycline and oral metronidazole. Hospital admission for pelvic inflammatory disease is needed if there's a risk of an ectopic pregnancy, if there are signs suggestive of pelvic peritonitis, if the woman is unresponsive to oral antibiotics, so IV antibiotics are needed, or if emergency surgery is needed, or if there's any sort of suspicion of an alternative diagnosis. Okay. So now we're going to look at haematocolpos. So to put things quite simply, haematocolpos is when there's an accumulation of blood in the vagina because you've got an imperforate hymen, or it could be described as a lower vaginal atresia. So if you have a look at the picture on the far right hand side, you can see that blood is just accumulating within the vagina and unfortunately it can't be expelled. So typically pediatric patients present with symptoms suggestive of haematocolpos, and they're presenting at an age at which they should be going through puberty, they should be experiencing the cyclical period, the cyclical menstrual cycle. So there are different types of haematocolpos. There's obstruction with menstruation and then obstruction without menstruation. So obstruction with menstruation is when there's a further non-communicating uterus or horn of the uterus and blood can't be emptied during the periods. An obstruction without menstruation is commonly due to an imperforate hymen or vaginal septum. So these patients will be complaining of primary amenorrhea and cyclical pelvic pain. So the SBA might give a scenario of a 16-year-old who presents to the GP and she's concerned because although she's suffering from cramping abdominal pain every month, she's never had a period. So that sort of scenario would be suggestive of haematocolpos. So she's a pediatric patient presenting typically during a point in life where she should be undergoing her normal periods. She's suffering from primary amenorrhea, so she's never had a period, and she has the cyclical pelvic pain, so she's having abdominal cramping every month. Okay. So in terms of tests, we need to do an MRI to exclude if there is any abnormal ureter or renal obstruction alongside with the menstruation, and we do colposcopy. So colposcopy in haematocolpos will identify a blue bulging membrane at the end of the vagina. So that's just a way of describing the accumulation of blood building up in the vagina. And in terms of management, we just need to perform incision and drainage. So now let's look at an ovarian torsion. So ovarian torsion is a complete or partial rotation of an ovary around its ligaments. Typically, ovarian torsions will affect the right ovary. So if you just have a look at these two pictures, you can see examples of an ovarian torsion. So risk factors for an ovarian torsion involves fertility treatment because this can lead to an abnormally enlarged ovary, and that acts almost as a leading point, promoting that twisting action upon the ligaments. if there's an ovarian mass more than 5 centimetres, women of a reproductive age, so women less than 30, 20% of women experience ovarian torsion during their pregnancy, and a past medical history of ovarian torsion. Another risk factor for ovarian torsions are ovarian cysts, because again they act as that leading point, allowing that twisting action to occur. Now, in terms of signs and symptoms, women will be complaining of right iliac fossa pain or left iliac fossa pain. They'll experience vaginal bleeding, a palpable adnexal mass, fever, and intensive management. This is typically a diagnosis of exclusion, and healthcare professionals need to perform a pelvic ultrasound scan, which classically presents with this whirlpool sign. So I've highlighted that in red because that's a very high yield phrase that crops up in medical school exams. So if you have a SBA in your exam where a pelvic ultrasound scan has been performed and a whirlpool sign was identified, then that should hopefully switch on the alarm bells in your brain, make you tick ovarian torsion, and then you can move on with the rest of the questions. So it's a very classic description of ovarian torsion, the whirlpool sign, so just keep that in the back of your mind. And we need to do a laparoscopy for both diagnosis and treatment. Okay? So thank you for staying with me throughout this very long video. I just wanted to quickly raise awareness about the importance of smear testing. So I do appreciate that some women might find the smear test to be uncomfortable. However, it's important that they do participate in the cervical smear program because it helps to identify women who are potentially at risk of developing a cervical cancer. And unfortunately, the impact of cervical cancer lasts a lifetime, and the smear test only lasts 5 minutes. And I'd just like to say a huge thank you for sticking with me until the very end of the video. I know it's been quite a long video, and I'd just like to take the time to say, if you enjoyed my video today, then please give me a thumbs up, please subscribe to my channel, and please post in the comment section below and share with your friends. If you've enjoyed today's video, then please do have a look at my channel and watch some of the other videos that I've made. Thank you very much for watching my video, and I wish you all the best in your finals.